Morning everyone. Now we will continue our discussion on pericardial disorders. Now this is the most important topic in the pericardial disorders, which is called as the constrictive pericarditis. This has got a lot of pathophysiological understanding that is required. So this is a very important topic both for a NEET examination and also for a final year examination. This will be one of the most repeated questions. So what is the constrictive pericarditis? Constructive pericarditis is basically a disease of a sequelae. It occurs following an acute fibrinous pericarditis or an acute pseudofibrinous pericarditis or a chronic pericardial effusion. All this condition over a period of time will develop into constrictive pericarditis. What happens is that once these effusions will get resolved, there will be obliteration of the pericardial cavity by a formation of granulation tissue. Between the two layers of the pericardial visceral pericardium, the effusion will be reabsorbed and there will be formation of a granulation tissue. This granulation tissue will obliterate the pericardial cavity. Later, this granulation tissue will go for fibrosis and result in the formation of a scar. And this scarred tissue will later go for calcification, resulting in the formation of a rigid inelastic pericardium. So, heart is surrounded by the pericardial cavity. What this pericardial cavity will become a wooden rigid cavity. The heart can expand to some extent, but beyond that extent the heart cannot further expansion. So this pericardium will prevent the expansion of the heart beyond the early part. So if, for example, the diastole has got the total of 3 parts, the first 1/3 part will be normal. The heart can be able to expand the first 1/3 part. The remaining 2/3 part it cannot expand because the heart will be compressed by this pericardial cavity. This is the main pathophysiology of constrictive pericarditis. So what are the causes of constrictive pericarditis? In India, tuberculosis is the most common cause of constrictive pericarditis. Other common causes of constrictive pericarditis can be radiation, can be because of histoplasmosis, can be because of SLE, rheumatoid arthritis, malignancies like leukemia, lymphoma, breast cancer, lung cancer. It can be following any cardiac surgery, or it can be following radiation, or it following acute idiopathic pericarditis. There are multiple causes, but in every cause will result in a final sequelae as a rigid inelastic pericardium. That is what happens. So what is the consequence? The basic pathophysiology here is that the ventricles are not able to fill with enough volume of blood. This is because the ventricles, to fill enough volume of blood, the ventricles have to dilate to accept the blood. Since the dilatation of ventricle is impeded by the rigid pericardium, it cannot accept the correct volume of blood. As a result, the left ventricles both the ventricles end diastolic volume decreases. So heart has to somehow accept this extra volume of blood. So what happens? The right atrium, both the right atrium and the left atrium, predominantly right atrium will go for dilatation. And secondly, the only part where the ventricle can expand is its early part. So there will be maximum expansion in the early part, and this expansion will come to a sudden halt. That is what happens. So this fibrotic process initially begins in the pericardial area. Later it can also involve the myocardial area. In that place it can present as heart blocks, or cardiac failure presentation can also occur. So what happen? The two basic things that happen in right ventricle in constrictive pericarditis is the right ventricle failure, and second is because of a reduced cardiac output. So how do they present? So the presentation is basically a right ventricular failure in the form of facial puffiness, raised JVP, abdominal distension, congestive hepatomegaly with LV dysfunction, with liver dysfunction, pleural edema, anasarca. This is the presentation. They can also have, because the right ventricle, the filling of right ventricle is decreased, the filling of left ventricle will also be decreased. This will result in low cardiac output. That will produce weakness, cachexia. These are the symptoms you have, the commonly symptoms. What are these signs? First, we have something called as Kussmaul sign. This is because during inspiration, normally the JVP falls. Here, instead of JVP falling, it can neither neither be at the same level, nor it can even increase with inspiration. This is called as Kussmaul sign. The second sign you have is called as Broadbent sign. This is called as the retractile apical impulse. The cardiac impulse will go in. Third, you have gotten pericardial knock, which is present near the third heart sounder. This is seen because of the constrictive pericarditis. The other findings include narrow pulse pressure, pulsus paradoxus. Because the pressure in both the ATMs will be increased, there will be prominent A waves. There will be the pressure tracing shows an M-shaped tracing between both the atriums. Also, what are the investigations? How do you investigate? So, basic investigation will be ECG. This ECG shows a low voltage complex, that is a common finding, or it can show T inversions or T wave flattenings that can be seen. Third, it can increase the risk of atrial fibrillation. Then it can chest X-ray. Chest X-ray can show signs of pericardial calcification. Then we do the 2D echo. The 2D echo can show the thickened pericardium. It can show a dilated inferior vena cava, or it can show a dilated hepatic veins. And also you can do a color Doppler. This Doppler echo can show an increase in the respiratory variations. During inspiration, the blood flow into the right side of the heart, namely across the pulmonary wall and across the tricuspid wall, will be increased, and correspondingly the blood flow across the mitral wall and the aortic wall will be decreased, and during expiration the opposite happens. These are the findings. You can also do a CT scan or an MRI scan for perfect localization of the pericardial thickening. So how do you manage? So what are the differential diagnoses for constrictive pericarditis? First differential diagnosis is cor pulmonale. Cor pulmonale is the right ventricular hypertrophy and right ventricular dilatation occurring in a case of chronic lung disease because of secondary to pulmonary hypertension. Here you can the findings of underlying chronic lung disease can help to differentiate cor pulmonale from a constrictive pericarditis. Second differential diagnosis will be tricuspid stenosis. Again, the finding of a mid-diastolic murmur in the mitral area, also the tricuspid area, can help to differentiate both this condition. Third is this condition can present as refractory ascites. So it's usually thought of as a cirrhosis going for decompensated liver disease. That is another close differential diagnosis. So how do you manage? So as in any right ventricular failure, we have to go for fluid restriction, salt restriction, diuretics. These are the medical management that can be tried. But the treatment of choice is pericardial stripping or pericardiectomy. That is the treatment of choice. Once you do the pericardiectomy, all the signs and symptoms will begin to improve over a period of time. But this surgery has got a high risk of, can have its own fair share of complications. You have to go for a pre-op the cardiac evaluations. If the fibrotic process involves the myocardium, in that case the surgery becomes even more complicated. So overall, this disease carries a really bad prognosis. It has to be differentiated from its close mimics like an cardiac tamponade, where in cardiac tamponade you have got both the wide descent will be absent in a cardiac tamponade, whereas in the constrictive pericarditis this wide descent will be prominent. That is the differentiating features between these two conditions. So summary, any patient presenting with refractory ascites or refractory ascites or pleural effusion or RV failure with very resistance to drug, all the diuretics, you have to think in terms of constrictive pericarditis. You have to evaluate an echo to diagnose the condition, and you should manage it with surgery. Thank you.